Hello, everyone. We're going to start shortly as soon as colleagues join the webinar. Thank you. Thank you all. We're going to start shortly. We will be starting in one more minute. Thank you all. Well, good morning, good afternoon, and good evening, everyone. And thank you for joining us today for this Grand Rounds. This Grand Rounds is one of a series of webinars that have been organized through a collaboration between ICAP and the Herbert Irving Comprehensive Cancer Center at Columbia University. These webinars are part of an initiative that has been established between ICAP and the Cancer Center here at Columbia University with the goal of advancing the diagnosis, prevention, and care and treatment for cancer globally. We are very happy today to have Dr. Grosebeck Parham join us to deliver this important webinar. Now, let me tell you a little bit about Dr. Parham. He is a US board-certified gynecological oncologist and a professor of obstetrics and gynecology at the University of North Carolina at Chapel Hill in the US. He has lived in Zambia since 2005, where he founded the Cervical Cancer Prevention Program, and he serves as honorary consultant and lecturer at the University Teaching Hospital in Lusaka. Now, Dr. Parham completed his medical training at the University of Alabama in Birmingham and followed by a residency in obstetrics and gynecology. He pursued further training in his field of interest at the University of London, as well as also at the University of Khartoum in the Sudan. From the earliest stages of his career, he's been remarkably committed to advancing the care and our knowledge base, as well as the care and access to services for, particularly for HIV-infected women in the United States, as well as for women in sub-Saharan Africa. He has been a primary investigator on numerous research studies with a focus on the integration of cervical cancer care services for women living with HIV, virtual reality surgical simulation to build surgical capacity, and the use of artificial intelligence for cervical cancer screening in resource-constrained African settings. He presently serves as the senior clinical expert for the WHO Cervical Cancer Elimination Initiative in the Office of the Director General of WHO. Thank you very much, Dr. Parham, for joining us today. And we'll move on now to your presentation. This will be followed after the presentation by a Q&A and a discussion period. I invite all of our listeners and to please put your questions in the Q&A box. And if you would please put in the chat box, indicate your name and your organization. And just as a reminder, this webinar will be recorded and the slides and the webinar itself will be posted on the ICAP website. So thank you very much, Dr. Parham, and hand it over to you.
Thank you so much. Good morning, good afternoon, or evening, wherever you are. I'm pleased to be your Grand Round speaker for today and to listen. I'll try to make this interesting. I'm speaking to you from Lusaka, Zambia, and my major objective today is to provide you with a few highlights of some of the work in which I have been involved, which has served as a windbreak for women in sub-Saharan Africa who are faced with the risk of developing and who have developed cervical and breast cancer, the two most prevalent and lethal cancers in women who reside in this region of the world. As I was preparing for this lecture, I meditated on a sermon by the late African-American theologian and mystic, Dr. Howard Thurman. The title of the sermon was, "What do you want, really?" In the sermon, he prods us to ask, what is the fundamental thing that I'm after with my life? What is the meaning of all the activities and strivings and the struggles? What, after all, is my point? What is it that is capable of making me bring to bear upon a single purpose or focus all of the resources of my life, my dreaming, so that in the fulfillment of myself, the answer to this question will follow? One Sunday afternoon in 1963 in Birmingham, Alabama, which is my hometown, I tried to purchase a ticket to see a movie at the all-white segregated Alabama Theater. I was arrested and put in jail. At the time, I was 14 years of age. Next slide. 3 months later, as you can see on these slides, Dr. Martin Luther King Jr. led massive civil disobedience demonstrations in Birmingham against racial apartheid and social and economic injustices in the Deep South. The response by the police, as depicted in these pictures, is well known. What thousands of Black youth depicted in the bottom right corner of your screen, between ages of 10 and 18 in what is now known as the Birmingham Children's Crusade. Again, the police responded with dogs as more and more youth marched in the streets and the jails were filled beyond a football stadium without food or water for several days. As you can see in the center of that, who participated in the Children's Crusade. And again, I was arrested and jailed at 16th Street Baptist Church into the streets of Birmingham in protest of our conditions. Next slide. Four months later, the church please go back. Please go back one slide. Please, thank you. Just stay right there. 4 months later, the church was bombed on a Sunday morning by the Ku Klux Klan, killing these 4 little girls who were attending Sunday school and injuring 20 other people. Next slide. Three years after the bombing in 1966, I entered Oberlin College in Ohio, where I became a student leader and activist. My activism and leadership earned me a false accusation, another arrest, time in jail, but the case was eventually nullied because the agent who set us up did not show up for the trial. Next slide. It was during this time in college that I began reading about the African liberation struggles and Pan-Africanism, and I began to connect the dots between the civil rights movement and the fight against racial segregation in Birmingham, Alabama, and the African liberation struggles against colonialism. Next slide. So I knew that a part of my life would be played out in Africa, but I did not know where, when, or how. What I'm now going to discuss in my Grand Rounds talk is a bit of the where, the when, and the how. Next slide. After searching around in various places on the continent in Africa, in 2003, I was invited to Zambia, which you can see on this map, to visit a large HIV care and treatment program that at the time was under the leadership of the University of Alabama in Birmingham. Some of the principals you may know, Dr. Robert Goldenberg, who I understand may be at your university, Dr. Sten Vermon, who is the Dean of the School of Public Health at Yale University, Dr. Jeff Stringer, who's at UNC, and later, Dr. Michael Sag at UAB. Next slide. During the time I visited Zambia in 2003, I asked to be taken to the University Teaching Hospital, which was the only tertiary hospital in the country at that time. Now there are two. I visited the gynecology wards and found that it was filled with young women in their mid to late 20s and early 30s, the vast majority of whom had advanced cervical cancer and were co-infected with HIV. When I asked about cervical cancer screening, I was looked at very strangely because there was a paucity of screening services at the time, and those that were performed, pap smears, were performed primarily on women who were already symptomatic. There were no radiation therapy services at the time, so most of the women, like this one young woman in the bed, and that's me in the center, standing there with a beige suit coat, most of these women died, and they died untreated. Next slide. Of course, as a gynecologic oncologist, I was of the opinion that a cervical cancer screening program for HIV-infected women could make a difference by detecting precancers that could be treated, and even early stage invasive cancers that could be treated with surgery. I was challenged to develop the evidence for this, and I went back to Birmingham and was able to garner a $25,000 CFAR, Center for AIDS Research grant from the University of Alabama in Birmingham. With that small amount of money, we performed a study in Zambia of 150 HIV positive women who were seeking antiretroviral therapy. All of the drugs were being dispensed by the university at that time. And we screened them with HPV test, cytology, and with something called visual inspection with acetic acid, where you put vinegar on the cervix and wait 2 or 3 minutes and see if it turns white. The results were astounding. Only, 83% of the women had high-risk HPV genotypes. They were infected. Most of these women were severely immunosuppressed. but the cytology of the women had normal pap smears. If you look in the maroon percent, we're already walking around with cytologic evidence of invasive cervical cancer. And if you look at the brown cut of the pie, it's of high-grade precancerous lesions. These lesions in HIV-infected women are known to progress. 50, 60, 70% will progress to invasive cancer. 30% in HIV-negative women. Women who were already infected with HIV, who were getting who already had cervical cancer, who were being put on antiretroviral therapy. We also saw a fairly large percentage of women who had precancer. And those precancers can be eradicated, preventing them from developing into invasive cancers. Next slide. Next slide.
Hi, all. Please bear with us for a moment. Dr. Parham has some low bandwidth and has dropped from the call and should be rejoining us shortly.
Let us just hold on for a while and see if this connection is better once he joins us again. Dr. Grosebeck, are you back? Dr. Parham, are you back?
Yes, I'm back.
Okay.
Yes, I'm back.
Please go ahead.
Fantastic. Okay, so cervical cancer is a disease in low and middle income countries that's driven by deep poverty. And because it cripples and kills women in these settings, it creates a perpetual cycle of poverty, as you see on the left. Poverty contributes significantly to cervical cancer, which then contributes to poverty because of the central role that women play in these settings in maintaining the family, the community, and the economy. In this study that is across the top of the slide, when I forgot, I did not put in the reference, and it's Cancer, the journal Cancer 2019. The authors used a simulation model to estimate the impact of a mother's death from cervical or breast cancer on child mortality. First time this had been done. From the 52 African nations, the simulation model predicted that for every 100 women who die from either breast or cervical cancer, anywhere from 14 to 30 children also die as a result. Now, the children die of the same diseases that are the most common causes of childhood death in these settings: diarrhea, measles, malaria, malnutrition, acute respiratory infections. But it shows the protective effect of the mother, the protective power of the mother to prevent children from dying of these diseases and what happens when she is crippled or dies and is no longer to provide care. Next slide, please. If you look at the slide on the left, it shows that cervical cancer has its highest incidence rates in the poorest global regions. The darker the color, the higher the disease incidence rates. And on the right-hand side, the map shows that women with HIV, which is another poverty-driven disease, have 6 times the risk of developing cervical cancer. But it also shows that the fraction of women with cervical cancer who are also living with HIV, the fraction is concentrated in sub-Saharan Africa, those areas that are colored, where up to 60% of women diagnosed with cervical cancer are also HIV infected. Next slide, please. These maps demonstrate huge gaps in human resources, that is, nurses, midwives, and physicians in these same global settings, which I just showed you. The lighter the color, the lower the ratio of doctors and nurses per 10,000 women. These same human resource gaps or disparities hold true for surgeons and other aspects or components of the surgical ecosystem, such as anesthesiologists, pathologists, laboratory systems, medicine, surgical theaters, radiological imaging, etc. The same holds true for radiation therapy and chemotherapy. Next slide. So if you just focus on the center, this information is in the center of this slide. In 2003, when I visited Zambia, this is the infrastructure, the cancer care infrastructure that existed. There was one cytologist for the entire country, one pathologist, no oncologist, no radiation therapy facilities, a limited number of practicing physicians. I think there were 12 gynecologists at the time, and one cancer advocacy group. On the right-hand side, from the time that Zambia gained its independence from Britain in 1964 up to 2003, when I visited, only 10,000 women had ever been screened with pap smears. And as I said before, most of these paps were performed in women who were symptomatic. But during this same period of time, 5,000 cervical cancer cases were diagnosed. The country was without any radiation therapy services, so the government had to pay for them to be sent to either Zimbabwe or South Africa, and they rationed the treatment. I sat in on one of these sessions, and it was really brutal to determine who would go, who would be sent, and who was not. The remainder of the women, over 4,500, died and died without any treatment. Next slide. So it was at this time that I decided, after seeing all of this and witnessing this as a gynecologic oncologist, what my point, as Howard Thurman said, what my point of life would be. And it was right after I made this decision that Dr. Sten Vermont introduced me to Dr. Moses Sinkala, a wonderful Zambian physician, he's late now, who at the time he had been at University of Alabama and I think obtained a master's or PhD in public health, and came back and was the director of the Lusaka public health system. Dr. Sinkala understood what I wanted to do. He understood cervical cancer. He understood the public health sector. And his philosophy was that you can do any research that you want to do in this country, but it must benefit the Zambian people. So he took me by the hand to the first 4 clinics in which we established cervical cancer screening clinics, knocked on the doors of the very powerful nurses who operate these clinics, and told them that they should work with me to help establish the first cervical cancer screening clinics in the country. And they were happy to do so because most of these women had seen large numbers of women coming into their public health clinics in these low-income communities with cervical cancer. So for screening we knew we had to do something that was cheap, that was affordable, that was scalable. Even though it was not the most accurate test, it had the ability to save lives by detecting high-grade precancerous lesions and earliest invasive cervical cancers, placing vinegar on a cotton ball and then soaking the cervix and looking for abnormal changes. Next slide. In the Western world, cervical cancer screening, a positive screening test, is followed by something called colposcopy. That's this big cumbersome machine on the left that can magnify what the human eye can see up to probably 50 to 60 times. This was unaffordable. It was not portable. So we replaced it with a commercial off-the-shelf digital camera, which we could purchase for less than $350. Next slide. We also found portable instrumentation that we could use to treat these precancerous lesions in the clinic, as opposed to taking women to surgery performing what was historically known as cervical conizations, because it required a theater time, which we didn't have. It required surgical equipment, which we didn't have, anesthesiologists. So we decided to treat these lesions in the clinic in an outpatient manner by freezing them, heating them, or excising them under local anesthesia. Next slide. So no one at that time, this was 2005, the latter part of 2005, when we first set up these first clinics, no one was funding cervical cancer screening programs at the time, particularly screening of women living with HIV, because most of them died before they developed cervical cancer. But our small study, the one that I just showed you, and those of others, and the increasing distribution and effectiveness of antiretroviral therapy turned the argument in the opposite direction. So that now the question became, what sense does it make to save a woman's life from HIV only to have her die from cervical cancer, a preventable disease? And because of that, and because of intense lobbying, we were able to obtain funds from PEPFAR, President's Emergency Plan Phase Relief, for cervical cancer screening. And we used the HIV care and treatment infrastructure for screening. That happened in 2006 in Zambia, and it was the first country in which PEPFAR funded cervical cancer screening. Next slide. We moved away from doctors to empower nurses. There were not enough doctors, and I was of the opinion that women would feel more comfortable in women-centric clinics. So we trained nurses how to identify these lesions. We equipped them with the camera, with a TV monitor, so they could magnify the lesions, looking for minute details that might indicate whether this was a high-grade precancer or an invasive cancer versus normal. And they can also show these pictures to the patient. And that was very important in terms of patient education and getting the patient involved in her care. We also equipped the nurses at the time with what we call cryotherapy that they could use to treat patients in the clinic. We also taught them how to perform what is called loop excisions of abnormal lesions, something that's usually only done by physicians. Next slide. Sometimes nurses had difficulty determining what they were seeing on the camera. And rather than to have patients come back for a second visit, most of which the time they did not make, the loss to follow-up was great, we decided to set up a telehealth system where the nurses could take those images, download them to a computer, and then send them to
Dr. Parham, we can't hear you now. It appears that you're muted.
How about now?
Yes, perfect. Keep going.
Okay,
Thank you.
now, next slide, please. Okay, we also hired a cadre of young people to use cell phones to track patients who missed their appointments. It's very important. And what we found was that if the patient answered the phone, 80% of the time they returned. But we had sometimes significant difficulty in reaching them because the phone numbers had changed or they no longer had the phone, et cetera, et cetera. Next slide. So as you can imagine, in this environment, the myths and misconceptions about cervical cancer were really deep. We did a small study in one of these large poverty-stricken areas where we had established a cervical cancer screening clinic, and we asked 1,000 women who had never been and accessed the services why. We asked them, what do you think causes cervical cancer, and why have you not been screened for cervical cancer? And the three most common answers to the first question, what do you think causes cervical cancer, were as follows. If you're found to have cancer of the cervix, that means you are a prostitute. Number two, people think that cervical cancer is not from sex, but from a satanic curse. And number three, having sex with a married woman's husband can give you cervical cancer. In answer to the second question, why haven't you been screened for cervical cancer? The most common responses were the nurses who do the screening are Satanists and may take our children, or the instruments they use are painful, or we are afraid to be cut by nurses. Next slide. So we knew we had to do something different. We knew we had to invest heavily in education and awareness. So part of that top left-hand corner, again, was nurses taking the time to show patients the pictures of their cervix and to explain what they were seeing. The top right-hand corner, we went into communities and invited very influential women in the community into sessions to show them the anatomy of the human body, female pelvis, and what cervical cancer looked like. Bottom left-hand corner, we used skits and dances and street theater. And bottom right-hand corner, we had multiple community awareness sessions throughout these communities. Next slide, please. We also knew that we had to find people in the community who had authority, who some women listened to. And these were the village chiefs, the traditional healers and practitioners, and traditional marriage counselors. Traditional healers and practitioners was an organization that had over 40,000 members. The same for the traditional marriage counselors. And these were very popular people. They were accessed by Zambians of all economic strata. And so we went out, spent a lot of time talking with these, what we call traditional infrastructures, educating them about cervical cancer, listening to their perception or concepts about the disease, the spiritual nature of the disease, the satanic nature of the disease, to try to reach a common ground. And we did, and they became our allies as opposed to our enemies. Next slide. They also helped us in developing mass cervical cancer screening campaigns in the peri-urban and rural areas. Next slide. As a result of this, when we started the program in December of 2005, and it was handed over to the government in 2015. We published this paper showing that we were able to effectively scale up cervical cancer prevention services with this model or this infrastructure, this platform that we had. And you can see we reached out to not only patients who were HIV positive, but those who were negative and those who did not know their HIV status at all. But you can see the rise in numbers. These were a paper about the first 100,000 women that we screened. The map of Zambia that's in red, if you look at this little small green spot in the center, that's where we were located. All the cervical cancer screening services were located in Lusaka in 2005, 2006. By the time we handed it to the government, it had been spread to, I think, 125 district primary health centers across the country. And that has continued under the leadership of the government. Next slide, please. Next slide. We also set up a very interesting, I'm sorry, go back. Yeah, quality assurance system where we use the pictures. Once every month we would meet, and the nurses, we would go over all of the pictures that the nurses had taken and evaluated their decisions. And we were, by doing this, we were able to increase the rates of same-day services. And we were also able to decrease a lot of the false positive screening results, things that nurses were calling precancerous lesions. A lot of those ended up being bad cervical infections. So this showed, we were able to show that these quality assurance measures actually work in improving the quality of services. Next slide. So over that 9-year period, from 2006, when we started as an NGO, to 2015, I think there's several accomplishments that were made. One, and to me, this is probably one of the most important, is that the program was institutionalized by the Zambian Ministry of Health in 2015. They felt it was effective enough, affordable enough, and scalable enough that they could take it and make it theirs and make it a part of their division of sexual and reproductive health. To date, over 1 million women have been screened for cervical cancer. Excuse me for leaving the R off of cancer. And this is, the country is now transitioning to HPV-based screening. We have seen a shift in early stage cancers from 24% to 42%. And the government, the hospital, University Teaching Hospital, because of that rise in early stage cervical cancers, in early stage invasive cancers, saw the necessity of establishing a gynecologic oncology super specialty and a gynecologic oncology fellowship to train young surgeons how to properly manage surgically women with invasive cervical cancer. And the funding has also increased. The funding from PEPFAR has obviously increased, but now there's funding from World Bank, Global Fund, and other sources. Next slide. Just a little bit about breast cancer, and then I'll be done. This is the way breast cancer presents in sub-Saharan Africa across the continent. Most women present with stage 3 and 4 disease. And one of the big problems is the long delay between recognition of symptoms by the woman and treatment, particularly the long delays between the time she presents to the clinic and the time she gets a diagnosis. Next slide. So trying to model ourselves after the success in the cervical cancer clinic, we demonstrated an algorithm where we put the whole pathway together, other than surgery, in a one-stop, what we call a one-stop shop. And we demonstrated this in a rural area in Zambia. I think we examined over maybe 1,000 women in a 1-week period of time. On the top left-hand corner, the woman would come in, she would be interviewed, if she complained of symptoms, or the nurse who performed a clinical breast exam felt a mass or saw bleeding from the nipple or some other sign of cervical cancer, they then, you see in the back in that third picture on top from the left, there's an portable ultrasound machine. The patient underwent an ultrasound and an ultrasound guided core needle biopsy. That tissue from the core needle biopsy, some of it was sent to the pathology lab, but some of it was also rubbed across a glass slide. And during this process, the cells fell off the slide, fell off the sample, and it really was a cytology sample, which the pathologist, which is in the second picture from the bottom on the left to the right, stained these slides and then looked at them on site, giving the patient a provisional diagnosis while she was there in that clinic. And it usually took about 2 hours for this process to occur. So we showed that you could do all of this in a one-stop model in the country. Next slide. Now, we also decided to take this same breast model and implement it in a stationary primary health clinic in Lusaka. And it has been very successful. That clinic there is a surgeon, a breast surgeon, a general surgeon in that clinic, who we were able to get some funds from the Susan Komen Foundation, and we sent him away to get training in breast cancer management in South Africa. And he came back and he set up this one-stop breast clinic in this primary healthcare clinic. So women come in, most are symptomatic. The nurse is there. She performs clinical breast exam. She does the ultrasound. He then does the ultrasound guided core needle biopsy. He gets a cytology sample. The patient gets a provisional diagnosis. The specimen, the core specimen, is then sent to the pathologist. And it is confirmed that she has invasive cancer, or she has a benign disease, it's very worrisome. He has been able to get them to surgery in this primary health clinic. So from the time she presents to the clinic to the time he performs surgery has been reduced from 3 to 6 months down to 4 to 6 weeks. And this is some early evidence that we may be seeing that he is downstaging disease. He needs more numbers, he needs more time, but you can see in red whether the stage 1 and 2 cancers over time have increased, and the stage 3 and 4 cancers, the red and the green, are decreasing, whereas the early stage cancers are increasing. The hope would be that the diagnosis at an earlier stage may lead to improved survival, but certainly it will lead to decreased morbidity. So again, the one-stop shop, now with surgery added, they come back for a second visit for the surgery. Next slide. I'm almost done. Next slide. We've been able to take the surgical model, the breast model that I just showed you, and implement it in the Democratic Republic of the Congo, and the surgical training model, which is a model of surgical intensification, where we have a local gynecologist save up 8 to 10 invasive cervical cancers, and then we go in and under very intense circumstances, train him or her how to perform radical surgery on these patients. Next slide. So in essence, I think the keys to our success have been as follows. Footprints in the soil, I would say, first and foremost. I think anything in which you want to, as they say, any plant that you want to see grow, a garden that you want to see develop, the best fertilizer is your footprint in the soil. So we're on the scene, we've been there, we are there, working hand in hand with our colleagues. We were also very willing to learn about, respect, and also we thought we could influence local beliefs and customs, and I think we have been able to. We empowered women to provide medical care to other women. We liberally used task shifting, but surrounded it with an intense monitoring, evaluation, and QA system. We integrated cancer care services at the primary healthcare level, so we took the services to the people. We emphasized community awareness. We incorporated appropriate technology where we could, and we are always very critical of ourselves. Criticism and self-criticism is one of the things I think that kept us afloat. And we were able to find ways to raise money. We never had enough money, but on the other hand, we did have enough money. Next slide. So I think if you ask me what was our guiding principle, I would say the quote by Bertrand Piccard, who was the pilot of Solar Impulse, which was the first successful solar-powered flight around the world in 2016. And he said it this way: you have to learn how to change your attitude in the winds of life, to find your way. Different ways of thinking, different ways of reacting, different ways of understanding situations. In life, you have to sometimes drop your certitudes, your common assumptions, your convictions, sometimes to be more flexible, to adapt to the unknown. Next slide. Thank you very much. That's the end of my talk. Thank you for having me.
Thank you, Professor Parham, for a really, really interesting and moving discussion, including your background leading to the work that you do that's changing so many women's lives. We're going to open it up for question and answer now. We have a couple of questions that have come in before the meeting, but also during your talk. So I'll start with one from Nina Phillips. Thank you for a very interesting presentation. In sensitizing and informing communities about cervical cancer, can you comment about communicating with male partners about the screening and care services? And do you have any thoughts on how communication can balance engagement of men and women in the woman's autonomy in their care?
Right. That's a very interesting question, and it's a delicate question. Zambia is a patriarchal society, and if you try to operate outside of that to the extreme, you'll find yourself in trouble, and you'll find that women will be prevented from coming to the clinic to access services. And so you have to work hard to provide women with the right to seek healthcare without anyone else's say so, but at the same time do it in a way that's respectful of the fact that she eventually at some point may end up consulting with her mate, male mate, or her male husband, particularly if she's treated for pre-cancer for 4 to 6 weeks, while I've gotten in the middle of Saturday night with men asking me about that recommendation, and sometimes women. But I think it's, so I think you have to be open. I think you have to provide women with the opportunity and with the right to invite their husbands, and I'm just going to say husbands, into the room for screening if they so desire. But if they say no, then you have to respect that right and say no to him. She's prime. She's the most important. But again, she operates not outside of context. She operates within a family, within a marriage, within a relationship. And so you have to be, again, it's a delicate, you have to be respectful. You have to ask her, would her mate like to be made aware of what's going on, etc. And we sometimes, when we go out into the rural areas, we will ask the chiefs and the traditional healers to assemble men, and we will talk to men about the importance of cervical cancer screening and where HPV comes from, and who, et cetera, and how they can, what role they can play in protecting these women who are so significant to themselves, to their families, and to the community and to the economy. So I think you have to try to have a positive attitude about it. And sometimes you find men who are very irate, belligerent, and you just have to deal with those issues on one-to-one. It's helpful when you can have high-level advocacy. If you have male members of parliament, male presidents, male members in these medical societies to talk to other men, I think is very important. But it's also important to know who the most influential people are in the community as far as the men and women are concerned. Sometimes it's ministers, sometimes it's traditional healers, sometimes it's just people in the community that you don't know, but they can identify. So it's all about education, 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 and understanding and appreciating and respecting the local culture while trying to influence it.
Great. We have two questions that focus on HPV testing and vaccination. So asking if you could share some best practices for incorporating HPV testing into the cervical cancer screening, as well as HPV vaccination programs integrating these efforts into cervical cancer prevention.
So here's what I think about HPV. I think HPV is a great test. It is a high performance test. It has great sensitivity. It will identify the largest, as a test, it has the ability to identify a very large fraction of women who will eventually, of the women who have cervical cancer and cervical precancer, HPV test will identify that fraction of women better than any other test. Now, epidemiologists and internal medicine doctors and some researchers tend to put a lot of emphasis on the fact that HPV screening, if the test is negative, it is very accurate, and the chances of that woman developing cervical cancer in the next 5 to 10 years is close to zero. They like to emphasize that, and that's important. But negative HPV tests don't kill anybody. The emphasis has to equally be placed on women who test HPV positive, because that's the group of women in which you will find the disease. That's why epidemiologists tend to end their engagement, and that's when the clinician has to get involved and speak out at the table, because it's he or she that's going to be responsible for finding those women who are HPV positive and who are at high risk for having precancer cancer, figuring out how to set up a system to find them, to bring them back into the clinic, to evaluate them with a triage test, which is the Vineca test, and then establishing a system for downstage management. It does nothing to identify a patient as HPV positive if you can't treat the disease that she may harbor. You just end up with numbers showing the percent that are positive, the percent that are negative, and you will never have a drop in disease incidence, mortality, et cetera. So the key to the HPV system is not only getting women in to get tested, but making sure that those who test HPV positive are evaluated, properly evaluated. And that requires developing systems, and it's been difficult so far to develop these systems. And I think that's where we have to focus investments and focus energy. What bothers me about some donors as relates to HPV tests is all they are asking for in return for their donations is the number of women who were tested with HPV, the number that were tested positive, the number that were tested negative, as opposed to of those who tested positive, how many were evaluated, how many were found to have precancer, what percent of those who had precancers were effectively treated, what percent of those who had cancers were also referred to treatment and were effectively treated. I don't think we can just stop with getting numbers on the percentages of women who test HPV positive and HPV negative. So I think it's a great test, but it has to be undergirded with the system of getting women back in and then managing them all the way down to treatment and follow-up. That's what I think about HPV, or else without that system, you'll never see the impact of the high performance status of HPV testing. It will go the way of the pap smear. You'll end up with a lot of tests sitting around. You know that they're positive, but the women were never evaluated. So you won't see any nudge in the incidence of disease over time.
Great, thank you.
As far as HPV screening, I'm a little disappointed at what has happened with HPV screening in low and middle income countries. I think that the move towards gaining greater profit by selling the supply of available HPV vaccines to men in Europe, and I have nothing in America. I have nothing against men in Europe and America getting tests for HPV, but I don't think that, I think there was some reneging on the original promise, and it was, has been said that it was because there was a decreased supply, but there are those who think that that what happened to the supply was that there was a market that was more profitable. People will debate that. Some people don't think that's the case, but nevertheless, I think my understanding is that there will be more affordable HPV vaccines. And if I said HPV tests, I mean HPV vaccines coming out of India and China. So we look forward to those. And I think we have to find ways to vaccinate young girls. I think Rwanda has done a great job. It is the model. Australia has done a great job, although they didn't do very well on their native population. But I think Rwanda, we can learn a lot from Rwanda. They're above 90% in the several years that they've been vaccinating young girls. And I think we have to find new ways to vaccinate them. You know, when mothers come in for screening, bring the young girls in for vaccination. When the young girls are vaccinated, if it's out of school, find a way to engage the mothers. I don't think we're being creative enough with HPV vaccines. And that is the ultimate answer. You know, vaccination to actually prevent HPV infections, but obviously that's not enough because we have millions of women who still are infected with HPV. I understand there's a therapeutic HPV vaccine that's going to go into clinical trials pretty soon. That'll be beneficial. So there's a lot of work to be done, but I think, again, there are lessons in Rwanda from which we can learn.
Great. We're at the top of the hour, but I'd like to get in one last question. But before I do, I just want to say that Tom and Edie Welty say thank you for helping to set up their cervical cancer screening in Cameroon in 2007. And they want a bit more information on ultrasound-guided breast biopsy, but maybe you can email with them to address that. I'd like to get to the last question about your work at WHO. And saying thank you for such a comprehensive and informative presentation. They are wondering how your experience has helped to shape the WHO strategy to eliminate cervical cancer. From your perspective, what are the biggest priorities to address in the African continent?
It's early. I've only been there, what, a year and a half. I'm just figuring out that that system. I don't think I'll ever figure it out, but I think it provides a perch. It provides a stage on which to push for more screening and treatment, and advocating treatment. You know, the WHO is not an implementing partner. They don't implement. They convene they make policy, and they develop guidelines. So I think I've been able to have some influence over guidelines development and a little in policy, but just trying to keep people focused on the realities of what situations are in low and middle income environments. We recently convened a group of gynecologic oncology societies in Western Europe, trying to bring them to the table with surgeons and gynecologists in low and middle income countries, so that the two could meet, and the field workers, the surgeons who are on the front line, can tell the European and American GYN oncologists what do they need to help build surgical capacity in their countries, as opposed to the other way around. So just trying to make sure, Susan, that the African field worker, the nurse, the person who's on the front lines, has a stronger voice in trying to shape policy and to say what's needed, as opposed to them always being told what they need to adjust to, which doesn't really work very well. So we'll see. But I've enjoyed working with Dr. Nono Similela and other colleagues at WHO. I think it's a great opportunity to try to have some influence. So thank you. And I'd like to say, I'd like to say hello to Tom and Edie. They've done great work in Cameroon, and they are two angels. If there are any angels on this planet, there certainly are two of them. They've done remarkable work in cervical cancer prevention and treatment. And I'll get in contact with them about breast cancer.
Wonderful. Thank you so much. I will hand over to Dr. Wafa El-Sadr to close us out.
Well, thank you very much, Dr. Parham. This has been really a wonderful presentation, and really you shared with us a very interesting and important journey in terms of how do we get to where we want to get to in terms of providing really the best quality of services, as well as also how do we scale up these services. So very much appreciate you sharing your insights and motivating all of us to think further and work harder at trying to really bring equity to issues around cancer prevention and cancer care around the world. Thank you all for joining us today, and hope to see you soon at another of our webinars. Thank you. Take good care.
Great. Thank you.